Share your screen and proceed. Kim, we don't hear you.
Okay. Can you see or can you hear my sound?
Yes, we can hear and see your screen now. Thank you so much.
Okay,
Please
thank
carry.
you so much. Thank you so much, Dr. Nicola my friend, and it's a very long time no see. And thank you for Dr. Salman, and it is my great honor to give a lecture in the International Neurotrauma Society of 2024. This time I prepared two topics of the endoscopic spine surgery. First topic will be the endoscopic lumbar interval fusion, and second will be the cervical posterior approach. Actually, we know that endoscopic lumbar interval fusion started recently and now can possibly do the uniportal endoscopic lumbar interval fusion and biportal endoscopic lumbar interval fusion together. I'm mainly doing the uniportal endoscopic lumbar interval fusion, and nowadays the approach point will be firstly starting from the transcambin approach, but nowadays in Korea and many other countries, they try the intraluminal approach and posterolateral approach. Actually, intraluminal approach very familiar for the surgeon because it looks like very easy. But if you have a more approach to the endoscopic spine surgery, you will be more familiar to the posterolateral approach to see here. And today I will talk about the posterolateral approach of the endoscopic lumbar interval fusion. And actually, this paper published by Dr. He, he talking that compared to the transcambin and posterolateral approach of the endoscopic lumbar interval fusion, it looks like the transcambin approach is also a good approach, but actually in the indication and the surgical techniques and the decompression and all point to the posterolateral approach will be more advantage compared to the transcambin approach because of that the many doctors try to this posterolateral approach. There have 10 surgical steps of endoscopic lumbar interval fusion of a posterolateral approach. Maybe first step will be the skin incision and the working channel docking. Skin incision point usually use the upper pedicle lateral border for use the same skin incision of the pedicle screw, and the docking point will be the medial border of the facet joint, same level with the disc level. And then now find the inferior articular process and superior articular process. You can see here the because of that, the next step will be the resection of IAP and resection of SAP. Because of that, this finding of facet configuration will be the very important point. Here you can see here they use the Woos point and Kim's point for resection of IAP. But before we use the mainly Woos point, but if you use the Kim's point after following this line like this, you can resect IAP more rapidly because of that. Then you can decrease the operation time more sufficiently. Fortunately, after expert like me, maybe you can perform in skin-to-skin one-level fusion by less than 1 hour 30 minutes is sufficient because it's more easy to resection of IAP and SAP using the Kim's point. And anyway, after that, next step will be the resection of IAP. You can see here like this shape, and then resection of SAP from lateral to medial like these steps. And then after resection of IAP and SAP, you can now estimate that the foraminal space is decompressed sufficiently. That is the first step to release the collapsed disc restoration. And then you can see this configuration under the endoscope view. Then insert the working tube, you can see this configuration. But you know that after that, we proceeding 2 steps of the very important point of the only advantage from the endoscopic lumbar interval fusion compared to the conventional surgery is that first is that chronic adhesive disc drilling, and second step will be the end plate denudation. You can see this is very important process of the endoscopic lumbal because of that. If we cutting the chronic adhesive disc point, then we can release the severe collapsed disc space and severe focal segmental correction. It will be very, very good using this chronic adhesive disc drilling. And second steps of the endplate denudation also very important because of that complete preservation of the endplate with a complete exposure of the fusion bed will be the two important points is that the one is the less surface rate and second step will be the higher fusion rate. That is our real purpose of the endoscopic lumen interval fusion. Because of that, these two steps will be the very, very important portion of the endoscopic lumen interval fusion. But before time, many surgeons worry about it. How we can deliver the KG from the surface to the target point because of that. Sometimes we do that some blind procedures of that because of that. Many doctors worry about that some nerve injury, but fortunately nowadays it introducing that. Working channel cage glider for protecting the traversing nerve root and acute nerve root from I made this and named this Harrison cage glider, and you can see like pushy and insert the disc line to the disc space and then rotate it like this shape, and then you can protect directly traversing and acute nerve root, and then you can insert the cage very safely to the target point. After that, you can search your target point after push the cage and then take out the glider and you can targeting to the cage to the target point. Then you can see doing the next step like this process. And this video showing that the whole process of the endoscopic lumen fusion like this resection of IAP and resection of SAP, and then expose the primary space and resect chronic adhesive disc drilling and endplate denudation, and then cage insertion, and sometimes two cage insertion like this. And then but fortunately, nowadays we see so many scientific basis of the endoscopic lumen interval fusion has a good clinical result. You can see this paper. I published so many paper about this, and in this paper of the old neurosurgery, I already introducing the Harrison cage glider, and it can apply to the degenerative scoliosis, and also this brain size paper talking that the resection of IAP using the Kim's point, we can shorten the operation time more, and we can do the operation more fastly. And then this paper of the Global Spine Journal of my paper talking that using the endoscope lumen interval fusion with the 3D print cage, we can take a more higher fusion rate compared to the open transformer lumen interval fusion, and the less substance rate in this paper talking there. And then this another paper of my paper talking that using the chronic adhesive disc drilling, disc height restoration, and spondylolisthesis reduction, and focal segmental correction, and reduction of spondylolisthesis will do the very, very effectively. And this is very important to correct the degenerative scoliosis and degenerative kyphosis using the endoscopic lumen fusion. And fortunately, nowadays, so many company introducing the 3D printed KG, and also we can take a more good fusion rate. And nowadays, we can do the 2 KG insertion techniques possible by the paper of Dr. Dongchan Lee. And this my paper already talking that. And you can see here the now there's so many good 3D printed cages like this 12 degree, 14 degree, 16 degree, 18 degree. This is very important to correct the focal segmental correction and the sagittal alignment correction in the degenerative spine. For example, like this case is L5S1 cases, it looks like very not easy to reduction and make angle in the posterior approach because of the many doctors before performing the anterior approach. But if we using this approach, we can more sufficient angle in spite of the L5S1. And also this case also similar cases and can insert more larger angled and it can more sufficiently make some more spinal alignment in spite of the L5S1 level. And also this cases or the failed face back surgery cases also need some sufficient discrete restoration and make angle, but it is not possible before in the posterior approach because of the main doctors performing anterior approach. But nowadays it is possible using the endoscopic interval fusion. You can see again like this large angled cage will be the very important in the endoscopic interval fusion. And also recently my paper talking that because of this large angled cage insertion, this kind of restriction also can take more sufficiently indirect decompression is possible. It means that only in the so many my cases only insert the cage only transforaminal space, not resection of ligament flavum, on the not decompression, only insert the cage in so many cases. But only some of cases like this severe stenosis cases need a decompression. And also using this advantage, our purpose of the spinal surgery, especially in the degenerative spine, we hope to no open surgery, no general anesthesia, no suture, no dressing, no transfusion, no infection. Hope to our dream, but it is possible using the endoscopic lumbar fusion. For example, like this patient, it received a 4-level lumbar fusion, but fortunately, this patient have no transfusion during the operation. Only one day after one pint transfusion done. And also after operation, you can see no suture, no dressing. It's done using the endoscopic lumbar fusion. Now I will show some of my cases. This case is severe collapse, collapsed spondylolisthesis cases in need of L5S in need of sufficient disc restoration and angle making. And after endoscopic lumbar fusion, you can see the sufficient restoration and the spinal alignment is corrected very well. And also this case, it looks like not difficult, but unfortunately, like this case is a verification of this large, high, this kind of space case is very difficult in the posterior approach and in the anterior approach, or because of that, it needs some larger cage, and because of that, higher chance of substance rate in like this cases. But fortunately, using endoscopic lumbar interval fusion using the large 2 kg insertion technique, you can see the sufficient insert, sufficient making the angle, spinal angle, and the sufficient correction done. And the patient also then take a sufficient clinical result. And also because of that, nowadays we can apply this endoscopic lumbar interval fusion for octogenarian patient more safely. For this patient, 85-year male patient also take a excellent clinical result after operation in spite of the severe collapsed disc stenosis cases. And also this another cases of octogenarian patient also need a 3-level fusion before. Like this cases is not easy by the fusion surgery, but it is possible using endoscopic interval fusion like this cases. And also so many cases I received the failed back surgery cases like this patient already received the interspinous device, but L5 was some failure. But after endoscopic lumbar interval fusion, we can take this excellent clinical result. This another cases, failed back surgery cases also can excellent clinical result using large angled cage. And also this another cases, failed back surgery cases also can take a sufficient excellent clinical result using the endoscopic lumbar interval fusion. Then nowadays we can possibly apply to the degenerative scoliosis and kyphosis cases. Also, I already published this paper in the World in Neurosurgery using the Harrison cage glider. And then, like this case is showing a 77-year-old female patient with the degenerative scoliosis, kyphosis patient also after operation, restoration, well done restoration. And also using this large angular cage has a very strong effect of spontaneous restoration effect, only after operation, but 1 month follow-up and one other cases of degenerative kyphosis cases also some post-operatively you see it here, and 1 month and 6 months and 1 year follow. And also some another cases of spinal alignment, malalignment cases also. You can see the renaming this tensegrity of the spontaneous restoration. And you can see like this post-operative and 1 year, 6 months and 1 year and 2-year follow-up. The patient have spontaneous restoration, have no PJK or junctional problem. In conclusion, nowadays so many endoscopic lumbar interval fusion by the uniportal and biportal endoscopic spine surgery developed so much, but it is very important to serve the good treatment to the patient, especially very older generation patient increase so much. But I believe that this innovative development of the spinal surgery, especially endoscopic spine surgery, will give more service to the patient treatment clinical result. Thank you for your kind attention.
Very interesting presentation, Kim, indeed. It was very interesting results that you're presenting, and as usual, you're pioneering the endoscopic surgery. Thank you so much for presenting the MCQs as well. We are preparing this to be sent to the patients as a to the participants as a Google form. Do you want to proceed now with the second talk?
Okay, can I talk next?
Please, yes, now.
Okay.
If you want to share your next talk screen.
Can you see?
Yes, all good.
Okay, thank you. Thank you, Dr. Nikolai, and I hope to next session that he give a very he writing very excellent talk. Yes, this talk my talk will be the endoscopic cervical posterior approach for degenerative spinal disease. This is my clinical data of the last 1 year. Among them, this is very important data because of it. In my clinic, about 99%, more than 99% of degenerative spinal disease treated by the endoscopically have no very small cases of open surgery. And then I already mentioned that endoscopy lumbar interval fusion will be a very important point, but you can see here the cervical posterior approach of the foraminotomy and central decompression also occupied about 10% of this endoscopy procedures. Because of that, some master and expert of the endoscopic posterior approach will be very important portion in the future. And also, I already mentioned that during last 1 year, 1,700 cases of open surgery, endoscopic spinal surgery, we only done 4 cases of HDF for open surgery only. For example, this case is open cases due to the myelopathy patient. This patient received the HDF. It means that without a myelopathy of cervical patient or another old patient can treat it by the endoscopically. Actually, endoscopical, we already well known that some cervical spine surgery mostly before done the anterior approach, but we know that there have so many complications. Oh, complications because of that. 2 overcome this problem, nowadays we try search the more good surgical techniques, and now to move to the endoscopic posterior approach. And so many unipolar surgeons and so many bipolar surgeons now doing the cervical posterior approach. And there have two techniques of posterior approach of the cervical foraminotomy and central decompression. And today we will talk together. And actually, the endoscopic spine surgery first is starting from anterior approach and posterior approach together, 2007 from Sang-Woo Lee and Dr. Sebastian. But firstly, anterior approach is more common, but there have so many limited indication and complications because of that. Then many surgeons hope to finding the posterior approach more safely. And this first step of the posterior approach will be the naming this viewpoint from Chiang Kim. And then next step will be the 3+ technique without traction, no skull clamp technique. This technique published by me. And then after that, many people talking that the cervical posterior approach may be better. In this paper, Dr. Yuchi talking that PCF may be a better choice for the treatment of CSR compared with anterior cervical discectomy. And another paper, Dr. Lan talking that in spite of the cervical posterior approach, before time we performing the open surgery, and we worry about the instability and the facet joint damage. But in this paper talking that in the cervical endoscopic spine surgery, instability is, it looks like a very good biomechanical performance, meaning that a very good stability. And I will show very interesting cases using this stability. And anyway, after that, at the initial time, we performing only posterior cervical foraminotomy, but there is very limited indication. But after publishing the paper of by me, partial pediculotomy and partial vertebral technique, you can see it. Partial pediculotomy and partial vertebrotomy. It means that the pedicle resection and vertebral resection together, we make a wider space of the working space, make more safely traction of the nerve and more safely approach to the target. Because of that, in spite of the posterior approach, we can perform near all pathology of the foraminal pathology, disc, stenosis, osteophyte, bones for all can possible posterior approach is possible. And also in the bipolar approach also developed so good technique like contralateral inclinator technique from Dr. Song. And also in the cervical decompression, we can follow this technique of, I published a paper of the thoracic OLF cases decompression by on-block resection over the top outside in technique. Using this technique in the cervical, we can decompression safely that need cervical decompression cases using this same technique. And anyway, in the cervical area, there have some typical anatomical characteristics because we should know these differences. First point is that the V point. V point, we can see all generation looks like same V point, but unfortunately, with the increasing the age, V point more close to the medial area from younger age to older age. And also spinal cord shape also changed by the age for like this. This 40 age and this 70 age. You can see this paper in Neurospine in my paper. Neurospine paper. I published this paper, and in the with the increasing age, V point more close to the medial and dura more close to the lateral. Because of that, using the same viewpoint with the older age, that is very dangerous to the cold damage. Because of that, you need more resection of the facet area more sufficiently and more laterally in needed. And also in the cervical area, more cautious anatomical structure will be the vertebral artery. You can see this paper also published by Neurospine. You can see, and because of that, sometimes vertebral artery very close to the nerve. You can see this vertebral artery. You can see this anatomical configuration in the Neurospine, my paper. And also, I already mentioned that if we need a osteopathic resection, we can doing resect that area after partial pediculotomy, partial vertebrotomy. Then we can approach more lateral point of the uncinate point to here. Because of that, if some patient need some foraminal ventral and post dorsal decompression patient, that all can possible this partial pediculotomy, partial vertebrotomy technique. And also, the clinical results of the endoscopy lumbar interval fusion before we know nowadays so many good clinical result paper published. This is my paper published in Neurospine talking that after follow-up 2 years, only a cervical posterior foraminotomy that has a good clinical result in the foraminal disc pathology. And also another paper of my paper talking that with the same foraminal pathology in the before operation and after current operation generation, before we mainly doing the HDF and or ADR, but nowadays the same patient or move to the posterior cervical foraminotomy, meaning that the generation completely changed from the anterior approach to posterior approach, especially cervical foraminal pathology. And interestingly, before time, in the open surgery using the cervical posterior foraminotomy, we usually save the facet joint less than 40% damage due to the more than 40%. We know that in the paper talking that maybe instability increase so much, and some kyphosis also happen more easily. But fortunately, in the endoscopic cervical foraminotomy, in spite of the more their spontaneous remodeling effect like this, and also you can see, and also because of that, like this complete resection of facet area cases, also with the 2-year follow-up, they have no instability, and facet also remodeled again, and they have no instability in spite like this cases. Because of that, currently, I'm so many my patients cervical posterior foraminotomy resect the facet resection more than 50%, but there for sufficient decompression is first. They have no instability, not using the unipolar endoscopy posterior decompression cases. And now we will see the cases. Actually, like this case is the C3-4 cervical disc pathology is not easy in the anterior approach before, but using the anterior cervical posterior approach, you can see, sorry. You can see here using the cervical posterior foraminotomy, you can see this disc substantially. And also, this another case is the 28-year-old female patient with a shoulder drop patient, the C5-6 also can remove the disc pathology sufficiently using only partial pediculotomy and partial vertebrotomy approach, and you can see after operation, and then shoulder drop recovered completely. Okay, you can see the okay. In these cases, you can see firstly searching the okay here V point, then here pedicle cancellous and cortical bone, meaning that here the root pass like this way, and then rotate the working space and move then some partial pediculotomy and partial vertebrotomy done, then traction done. You can see the protrusive disc exposed, and then disc also removed from traction, and then finally you can see the sufficient disc removal and the disc nerve decompressed sufficiently. You can see. And also this another case is the shoulder drop patient also recovered after sufficiently recovered completely 3 months later after operation using the same technique. And also these cases also have some foraminal stenosis with this pathology together. Then using this cervical posterior foraminectomy, you can see C5, C6, ipsilateral and contralateral. Then this pedicle and cancellous and nerve root here. Then after partial pediculotomy and partial vertebrotomy, then you can move to the target point, then expose the disc, then drill ventral area together. After that, you can see decompression sufficiently. And in the cases of this case is also interesting cases of spondylolisthesis combined the C5, C6 together and the foraminal stenosis case together. In this case, we can decompress this area sufficiently using the total pediculectomy procedures. And after 2-year follow-up, the patient still have no pain, no instability. And I will show the cases of cervical decompression because this is also very important. And also at the initial time, I'm only doing the single level decompression like this. I already mentioned that this outside and over the technique like this, drill, ipsilateral cranial caudal, contralateral cranial caudal, and remove the ligamentum flavum by one piece like this way, and preoperatively and postoperatively. And I'm also doing these procedures at the initial time, 2-level cases like this. 4, 5, 6 level differently, but at this time I know that it is not sufficient decompression done. Because of that, after then I'm doing the like this hemilaminectomy done to combine. Then I take in the 2-level decompression cases also take a sufficient decompression like this. Sorry, this. But I already mentioned that we should keep the over the top contralateral outside technique. Firstly, drilling only, and then finally take out the ligament problem. Because of that, in the cervical area, drilling, punchy, RF is fluid irrigation pressure is very, very dangerous to the cord damage. And I will show another cases, C5, 6, 6, 7 cases also post-operatively using the hemilaminectomy and decompression cases. Also, you can apply to the 3-level cases also like this, partial hemilaminectomy together, and this also can possible. 4-level cases also can possible like this. This hemilaminectomy done. Yes, in conclusion, nowadays endoscopic cervical posterior approach mainly is done by the cervical posterior foraminectomy and decompression. But unfortunately, still the endoscopic decompression is very dangerous for the spinal cord injury. But we should always give the caution, and if we take it take actually I followed the so many about 1,000 cases of cervical procedures, and so typical advantage will be with the long-term follow-up. The patient mostly they return to normal life, no instability, no limitation of their neck motion.